honestly, it's been a very emotional moment, Bansi. And Bansi Saab, thank you very much. Thank you. And thanks, Dr. Agrawal. Thanks, Dr. Professor Basant Kumar. And thanks, my friend from Delhi, Dr. Makkar. So thanks, RSSD. I really mean it. I'm so proud to be standing here. Can't believe it. You have to test my, all the testosterone to epinephrine to all levels to prove it a point. But honestly, it gives me immense pleasure that somebody started thinking of diabetes 70 years ago. And look at us, we are still in primitive stage. We don't know what to do with diabetes. I know it's sometimes very difficult for us to imagine that. So visionary, I was just reading more about it when I got awarded and read about him. And obviously, I personally feel I may be wrong. The M. Vishwanathan and the further lineage has done the most medical research in the country. I'm not talking diabetes. I think, and I probably have a narrow mind from diabetes endocrinology, but the amount of the data they have created, just imagine the whole Chennai group not contributing towards the data. And in India, I can't imagine diabetes without that. So I owe it to them. And it's encouragement, especially, I would like to young graduates to think on those lines. Practice was come in, but start thinking of what he wrote, what was his ambitions. I was looking into it, that create their own database, create their own clinical research work. So that's what the whole foundation of RSDI is, research foundation. And that's what we are all talking about it, as Bansi was talking about. So, we always have lecture invitations. The oration this first time is for me, and honestly speaking, again, honored. I'm sorry for being repetitive on this. We always had a time to talk about, but good that to have 30 minutes for the first time. Normally get 15, 20 minutes time. So thanks again. And again, I have no subject being offered, and I was decided to talk what I can do. That's another powerful I'm feeling today. So thank you very much. So, my study, the journey started, when I settled from UK 15 years ago, got into the practice, and thanks to Delhi for accommodating me who are not from Delhi. And I must owe it to Delhi as well, and Max Healthcare, which accommodated me, allowed to start working on research. And then, my UK connections, and in the connection, I must also thank one person, my father, who has his 89th birthday day for yesterday. He's got publications in NEJM, Lancet, BMJ from a small town called Muzaffarpur. Some of you would know Dr. T.K. Jha, so sorry I missed that. He has got possibly one of the largest publications in this country. So I owe to them. So when I start thinking of research, I think of my father, and obviously so many other people. So I owe to them as well. So I missed that, my family as well. So this epigenetics, started studies 2011-12. The idea is that why we have diabetes in this country 2-3 times. We have 30 times more cataract. We have 3 times more cardiovascular disease. We have 3 times, every data you look into, you see so many things happening. Why? Do we have data on MODI? Do we have data on preventions? We do have prevention data. And what is going on, the status of diabetes in India? So, ambition, maybe, in this country, we start late. From the age point of view, in the European countries, in Western countries, start young. But here, that's what it is. And you have to accept and adopt, because in the earlier part of the career, you tend to settle down with your job, your graduation, post-graduation, settling down financially. So it takes a bit of extra time. You become a little older. But that's what my journey started 10, 15 years time. And that's what I'm trying to talk about. The theme, we have an increasing incidence of diabetes. We all know about it. All the members of RSDI understands this, and there is an epidemic proportion. This COVID-19 exposed the diabetes status of India, and those people who think, oh, diabetes is kuch nahi hai, aisa hi hota hai. So the point is, what is diabetes now? Unfortunately, the COVID-19 and exposed people and say, oh, this is what it is, because people with diabetes have 2-3 times more incidence of getting to hospital, ICU, death, unfortunately. Now, I hope they don't question the diagnosis of diabetes now. In data, again, led by Mohan's, is a huge incidence of diabetes, 13%, rural-urban divide, that's what they talk about. But we all know, as a practice from a small town, a big town, small center, wherever, the incidence of diabetes is going up rapidly. This is data from 2010. But one thing is very odd. that we in India, we in South Asia, we believe that whole South Asia is South Indian continent, and we believe that South Asians have more risk of diabetes. Are they living in the United States? Are they living in Singapore? Are they living in the UK? Or they're living in South Hall? That's what the problem is. For the same, and I keep telling my young researcher, for the same speed, you have car speed on a M25 London, you have 3 times much more risk of accident for the same waist size, mind it. For the same waist size, for the same age, you have 3 times much more risk of diabetes, which came from Lollipop data and several other data. And this data coming from, led by, again, Dr. Mohan's group and Dr. Gujral et al. Published this data. This is what it is. For the same age group, you have 3 times. European males and Indian males, EW is Indian male and Indian females. So for the same age, compared in South Hall, living in South Hall, which has the same environmental exposure. So I have a doubt about environmental exposure creating diabetes in London among Asians variant. So they have 3 times much more risk of diabetes. And our data of almost 30,000 must contribute 15,000 coming from Anjana and the team, almost 15,000 coming from our data. We have seen that every quartile of income in India compared to any country. This is a large consortium that we have created of our near next door friend from Bangladesh to our next door friend from Pakistan and Sri Lanka. So we have a large consortium which we have created, but every Asian country has got more income, the more the diabetes is all about. So this coming from Dr. Mohan's review around 5-6 years ago, we Indians are more, what's the reason? There are a lot of questions not been yet answered. We need to answer the questions that why we have more diabetes, that increased plasma adiponectin levels to plasma leptin. There are several millions theory, but we can't pinpoint yet. So everybody will say, look, it's genetics. I can tell you that large data from Prof. Nikhil Tandon to Hyderabad data, it's not genetics. It's been proven it's not genetic. Type 2 diabetes variants across the board between Europeans and Indians have not shown any color, any trend towards type 2 diabetes among more Asians. Our first work was almost 7-8 years ago, that we did epigenetic study, and what we found that certain epigenetics, epigenetics was also a new word for me when I started getting into the research, because I'm a hardcore clinician. It's the environment effect of the genes, and the genes tends to interplay. That's what the large number of diseases have been implicated in it's a very new phenomenon we found out, and mainly you must read about it, what's the epigenetics about it, because all the omics study is the forefront for reason for diabetes. This depresses me. Though I'm happy that a country like UK have cut down almost more than 70% of the cardiovascular disease in the last 20 years' time. Europeans and Americans have cut down the cardiovascular, cath lab, bypass surgery by 70%. Can you imagine that happening? What's happening in Ahmedabad, what's happening in Patna, what's happening in Delhi, we all know about it. The risk of cardiovascular disease gone other way around, 35% increase annually. And it's why somebody dying, suddenly people talk, kyun hua, aisa kyun hua, suddenly who died, why? People need to be screened. I'm not saying everybody has diabetes or high LDL or high blood pressure, but our data suggests that this is something we need to accept and move on and say, look, we need to do something about it. When I was a young trainee, I could not understand what his National Services Framework was about it. In 2000, the government of NHS created that national framework, it's chronic screening every person of 30, 40, I don't remember exactly what cut-off age. And they started screening everyone. They started paying GP to get HbA1c below 7, blood pressure below 130/80, LDL below 90. And what they achieved is this. So why can't we achieve it? Simple. It's a total treatment cost, screening cost may not cost more than 200 rupees, 300 rupees to screen, and then move on to treatment aspect. It's going to be much more. People say, look, all these doctors have decided to treat with XYZ drug. The question is, if you treat them, you don't spend a couple of lakh rupees, bypass surgery, renal failure, we can't afford. So the idea is to screen, understand why we have diabetes in India. So the idea was to create a surveillance program in diabetes, and that's what it is. National Service Program has been halted because of the reasons we all know. It has a few thousand people. Kerala, Punjab, certain states have done well. As you know, Kerala is quite advanced in that. Almost 20% people with 29% males have diabetes, cardiovascular disease. These numbers, nobody will question us. Prevalence of hypertension, 40%. Half the population, Punjab, hypertension, early death. If you have blood pressure 140/80, if you are 30 years old, the risk of cardiovascular mortality is 2 times much more. So this is what it is. The NCD surveillance program in India requires more aggressive data. That's what this Oration Award is all about. Dr. Vishwanathan wanted this to happen, and that's what should take on further, and there's a need for it. India has got huge lifestyle environmental factors. There's only one data on diet which is proven, that if you are living in a Mediterranean country and if you are doing Western diet, Mediterranean means Italian and Spanish people who switch from Western to Mediterranean diet, that prevents cardiovascular disease. That's only proven data. The rest, yes, we all know there are what good food is, what bad food is, no doubt about it. But the proven to reverse the cardiovascular disease or prevention of diabetes, mainly CVD, is mainly from Mediterranean diet. And there's a lack of diversity in the population-based research. India does not contribute. We almost contribute to 20% of the world population. And number of biobanks, number of research we contribute from India is quite limited in that context. The whole public health, personal interventions needs to be shifted towards you're right, and that needs to be done by doing screening, by doing surveillance, by doing screening and started treating, and obviously translating the precision population medicine. We have a huge collaboration, so thanks to my mentor sitting in Singapore, sitting in London, sitting in Cambridge. We work together, sitting in South India, Chennai, Anjana and Dad. Wonderful colleagues. We work with Dr. Prasad from Sri Lanka in BRAC. We work together. We used to work together and had a physical meeting. Hopefully, we'll start having those physical meetings. We have contributed the least biobanking. Biobanking is to collect biological data, blood sampling, clinical data, long-term follow-up. That will tell us why diabetes is happening in the country. I must say that we are proud. Look at that email. The first time the whole consortium, which includes South India and Pakistan and Sri Lanka and Bangladesh, we contributed almost 15,000 of this, and we have created the largest South Asian biobank. So we're collecting around 6-8 blood bottles from each sample, a huge clinical data attached to it. I am working Max Healthcare, not a single patient is from Max Healthcare. They've gone down, we map the population, enumerate people, and then call to our center. It's not an open invitation. We do population health screen through and through. We are getting a good data, even lung function test, point of care blood testing, ECG. I must tell you, the ECG machines that what we have in surveillance centers in Delhi, and we have tied up with South Delhi Municipal Corporation Hospital, and we are based at there, and we call people. Somebody walks in, we have to politically correct and do certain testing for them, but the data what we include is based on enumeration data. That's what the public health research is all about. And overall, we have contributed, I'd say, 70,000, almost more than 1 lakh across the country, including Sri Lanka. This is the basic data crunching. We have hypertension, India. This is not the population of Max Healthcare, private healthcare. These are poor people. We have a huge economic data. We have WHO STEP survey. So this is what it is. 27% diabetes. We are talking about these poor people with comorbid conditions who can't afford to be screened have diabetes and blood pressure. And some data, is also coming from my hometown, Bihar. And I'm a bit surprised. My father did research on leishmaniasis, and I did research on diabetes. So it's such a transition from tropical disease to NCD. We are doing dietary physical survey. It's not easy. It's very difficult. It takes 2 hours to get the data of diet in India. It's not easy. They don't take a packed sandwich. They may not eat till 2 a.m. When we had meeting with the Cambridge, Nita Faruqi is a chief nutrition professor. He said, Dr. Jha, how can somebody not female not eat till 2 p.m.? I said, you have to come to India to collect it and start doing it. So there was a lot of red mark on data questioning. And then we sat together and said, look, this is what it is. Unfortunately, there is a different variant of population than what we have. So we risk stratify them, get into it. The idea is Biobank create the whole omics, whole proteomics, metabolics, phenomics. I'm not a metabolic expert. We need to tie up with people. We need to talk with people. We need to work together. That's why I'm here and inviting all RCI members to join hands. And I can think of working here, and I was talking to my friend Bridge, we need to sit down and see that how can we work, collaborate together, work together, ultimately get the work. That's what we're all sitting for here, molecular phenotyping. We also decided to look into what the ASHA workers manual is, and we decided to change certain things. I would like Bridge and Bansi to work on this manual and present to Government of India on this manual, and I will share, we have just finished this manual on innovations of ASHA workers. This is my addition. I have limited expertise, but we sat down with ASHA workers in SDMC Hospital, Delhi government. We created the whole manual to see कि करना क्या है ASHA workers को. We all know diabetes to be prevented. We have created ये होना चाहिए, but कैसे होना चाहिए? We decided, this is thanks to this pandemic, unfortunately, this last 2 years, that we could sit down and work on this policy mapping. We're also working on looking at the fast food and availability of food and risk of diabetes. This data coming from Sri Lanka, Colombo, they have linked fast food, obesity, diabetes among females in central Colombo. That Colombo districts are divided into different 9 districts. We work with Dr. Prasad and Anu. Those are both a professor. One is endocrinologist, one is public health research. We worked on that community-based interventions, and they found the link of diabetes first time in South Asia, what we call the GIS mapping. So diabetes prevention, we need to screen, then what do we do with them? We need to prevent it. We need to start early. We need to pick up impaired diabetes. If we don't do screening, we won't be able to prevent it. We need to start early. So what worked so far, this summarizes, we all know about it. Though there is, coca and tea, I'm not going to talk about it, but, we all know high fiber diet and processed meat is bad, fish is good, nuts is good, fermented dairy products, dahi is definitely better. That's what the evidence suggests. Fruits, better. That's what the evidence, but we need to create more evidence. We all know about cereal fibers, intake of trans fat, glycemic load. This all contributes towards increased risk of diabetes. So there are 4 diabetes prevention studies well proven, right from Finnish to China to, different 4 studies, which has clearly shown that diabetes can preventable. And also the Darkwing study, long-term follow-up, also 30 years follow-up, has shown decreased cardiovascular mortality. That's a wonderful data. That's what we have. The Chinese prevention data, long-term follow-up data did show. Though other studies, DPP and Finnish, didn't show much, but Chinese study, it's interesting, coming from Asia, showing that they also decrease the microvascular disease, which you can completely understand, but also mortality as well. This is the data from Dr. Ramchandran was spoken about this morning by Bansi, IDP prevention data. Even if you don't lose weight, you do the dietary conversions, you still prevent diabetes. That's what the data is about. Now, majority of the study has been done outside the country. So when I looked into the data of South Asian diabetes prevention, yes, DCLIP, IDIP, certain prevention data has come up here. And this is IDP studies which showed that even if you don't, just changing of diet prevent diabetes to a large extent. Same thing, the DCLIP data from Mohan Satal, that cumulative incidence of diabetes cutting down drastically. So that improving South Asian patients' interventions does improve. So if you look at the number, is total 7 Western countries, 2,500 people only. So this study was designed almost 7 years ago, just published in BMJ. We talked about what is already known, that South Asians have more diabetes. This was published last week, one of long-awaited publications after 7 years. What we did show that lifestyle modification delivered by the community health workers, South Asians, including India, raised HbA1c waist circumference is effective in reducing both weight and waist circumference at 1 year. It's very difficult to follow long-term prevention study in India. People don't end up. It's a very tough job. I've spent hours calling patients, requesting them to come in pandemic times. I don't know, sometimes you feel how far you have to go. Am I trying to help myself or help patients? Sometimes you get confused, but you get motivated because you have initiated study, you spent so much in initial time, you need to get them follow up. to get a follow-up up to 90% is so tough in South Asian countries compared to the Western countries. So I do understand that collection data, so this involved different 4 centers. So, I'm not going to talk because we are a little late to start, but I'll finish in 5 minutes. Yeah. So we did screening based on HbA1c, and that was a call because random HbA1c can be done, but as you know, fasting is difficult in the country to get it into large. We screened more than 20,000 population across the South Asia. In India, more than 7,000. We did community interventions. We did a DPP prevention model. I would say that because people know DPP prevention model, but we modified completely on Indian context, India, mainly North Indian context, and we have proved that the whole trial profile, I'll just come back to design. So what we did is that validated interventions, and we had a different booklet, different, different telephonic to different interventions. What we found that mainly the weight loss is 1.6 kilograms, little effect on the waist and blood pressure, but not both in HbA1c. I'm sure you're not surprised because we picked up an HbA1c which was much lower range. To see the difference in HbA1c in 1 year or 2 year follow-up was difficult, but at least didn't went up in the intervention group, but definitely 1.6 kilogram weight loss. You might find it, oh, it's nothing. I lost 5 kilograms in the last 5 days. The question is community interventions, in an intervention into randomized control, into dietary, into control group, getting that data and talking about it is tough to stand up and talk on publications based on that data. But this needs to be translated into practice. Otherwise, this just become one of those publications which I'll be happy on. So the global implication news study is a low resource setting, which we are. We're not proud to say that, but measuring waist cuff circumference by standard methods, identify people with type 2 diabetes risk. So that's also suggested that waist circumference has a good correlation with HbA1c. In South Asian countries, both weight and waist circumference are both causal path for type 2 diabetes. And I must say, this is our first data. We're going to crunch more data because we have biobanking for these whole population, and we'll have multiple data coming up on series. We expect 20, 30 publications out of this first study. So why COVID? Because 1st of April 2019, I had a research team of 30 people, and I thought they can't sit and I can't sit. We registered the first clinical trial on our team on healthcare workers. We started collecting sero sample 1st April 2020. Epidemic was declared in India 23rd March. 8 days later, the whole research team started collecting data 1st of April. We were not knowing, and I was not an expert on it. I do not claim to be COVID expert, but I had a team of 30 people. I said, let's do something for COVID. Let's start collecting blood. पूछा डॉक्टर साहब क्या करोगे ब्लड का? मैंने मुझे नहीं मालूम. There are very intelligent people across the country who will understand what to do with the blood. And thankfully, we spoke with IGIB, and they did large number of studies. So we did, now stop doing COVID research because we're back to normality, hopefully. So we did large number of data on vaccinations. We did, I would say that one of the longest post-vaccination healthcare data on Covishield. We did it not sponsored. Must say that, not sponsored at all. It's all internally done, not a single money from any company on that. Only we later on, government funding from IGIB later on, and that too later on. It came 6-9 months later because we team were funded. I wanted to sit down at home. So we did large number of COVID research, and ultimately, we're talking the number here is quite large on healthcare's vaccination seroprevalence. And ultimately, we got funded for this funding for MRC India partners. So our 30,000 cohort of metabolic cohort, we're linking with COVID research, and we already collected 5,000 samples correlating the cardiovascular risk profile with seroprevalence with COVID-19 data, which I call myself as a chief operating officer, not even CEO of this research company. It's just, I operate things. There are so many scientific people that you can sit down and collaborate. They think for you. You don't have to think about it. It's the IGIB which think about us, thinks about the molecular part of it, and we give them, collect solid data. That's very important, solid data. That's what we did for COVID. So time to join hands, and happy to work with RSTI, and happy to work, I was talking to Bridge, Bansi, I owe it to you guys. And I'm happy to work and take it forward. And India is a huge population, and I owe to the Dr. V. Mohan and his family, who's created such a wonderful data, and Anjana is going to be evolving such a wonderful researcher as well. So I work with her as well. So I would like that we need to work, and small, rural, urban, we need to work somewhere. We need to sit down. Thankfully, we are out of this pandemic, and we like to join hands and work together on research and diabetes. Thank you very much. Thanks again.